Hello, everybody, and welcome to today's webinar on the MIPS final rule presented by Anatomy IT. My name is Randy Marsden, VP of Value-Based Care here at Anatomy IT, and I'm joined today with Jessica Peterson and Renee Fryer from my team, who are here to present the final rule of what to expect next year for 2024. Take it away, Jessica.
All right, good afternoon or good morning, depending on where you are. Welcome to today's webinar on the MIPS final rule for 2024. Today, we're going to go over a quick overview of MIPS. Then we're going to go through the categories of cost, promoting interoperability, improvement activities, quality, and we'll have time for a brief question and answer at the end. Again, as Randy said, my name is Jessica Peterson. I'm the Senior Director of Value-Based Care Policy here at Anatomy IT. And let's get started. So 2024 MIPS, quick overview. What is MIPS? It's part of the Quality Payment Program, or the QPP. This was put in place by the Medicare Access and CHIP Reauthorization Act of 2015, or MACRA for short. This was a fantastic law in that it ended the sustainable growth rate formula. For those of you who don't remember, this was responsible for Congress having to pass a quote-unquote doc fix every year to avoid a 20 to 30% pay cut under Medicare. So it was a huge win there. But it also put in place the rules for the road for what Congress termed value-based care, telling CMS to create the Quality Payment Program, which has two pathways. One is advanced alternative payment models, or advanced APMs. These require you to take on financial risk. If you're not practicing at a hospital or inpatient, you're likely not in an advanced APM. You're probably participating in the fee-for-service arm, which is MIPS, the merit-based incentive payment system. And that's what we're here to talk about today. So, why is MIPS important? It's important because it impacts your Medicare Part B physician services reimbursements. There are a couple ways it can impact that. One is it could give you a penalty. Another is that it could give you a bonus. So in 2024, the threshold to avoid a penalty is a MIPS final score of 75 points or higher. Anything below that, and you'll get a penalty. It happens on a linear sliding scale, so the worse you do, the bigger your penalty is, up to a penalty of 9%. On the flip side, you could get a bonus if you get above 75 points. Anything from 75 to 100 points, and you get what's called the budget neutral bonus. This is also determined on a linear sliding scale, so the better you do, the more you get. But as I mentioned, it's budget neutral. And what that means is that all of the bonus monies for that year are determined from the penalty monies from that year. So how much you get is also determined by how many people are penalized and by how much. So how you do in 2024 will impact your 2026 Medicare Part B services reimbursements. So as I mentioned, there are penalties and bonuses that happen on a linear sliding scale. This is just kind of an overview of the last several years. You'll see there hasn't been much change in the threshold to avoid a penalty or the ranges, except that 2022 was the last year for the exceptional performance bonus. So 2024 is the last year you're going to see that on your payment reimbursements. One thing to note, however, is because it's been stable for so long at 75 points to avoid the penalty, we do expect that to increase soon. In fact, CMS actually proposed a threshold of 82 points to avoid the penalty in 2024. They didn't finalize it. They're keeping it at 75, but it's a good thing to keep your eye on moving forward. So how do we get a MIPS final score? It's determined by the four categories I mentioned earlier: quality, cost, improvement activities, and promoting interoperability. Quality and cost are both worth 30% of your MIPS final score. That's required by statute. The MACRA law itself said quality and cost have to be 30 within 5 years of program start. So unless there is a statutory change, those weights are here to stay. There's also the promoting interoperability category, which measures your EHR use, and improvement activities, which measures how you do activities that could improve your practice. These categories together create a composite score, which creates your final MIPS score. There are situations in which you may not be scored in one or more categories because you have an extreme or uncontrollable circumstance and apply for a hardship. In those situations, the weight will be redistributed to the other categories. So let's get into it. Let's talk about cost. This has been a huge topic of conversation this year because we're finally now seeing MIPS cost scores from 2022. For most of the pandemic, there were no cost scores because CMS reweighted them because of the impact of the pandemic. So now that we're seeing them, we understand how important this category is. Let's go over some basics. Cost is a full year performance category. So the CMS looks at the entire year of data. The number of points that you can get within the category depends on how many measures you're measured in. So for instance, let's say you're in an ophthalmology practice and you do cataract, but just cataract, you don't have any other specialties in your practice, you'll only be eligible for the cataract cost measure. Same if you're in derm and you don't have another specialty in your practice, you're probably only going to be eligible for the melanoma cost measure. So in both of those cases, since each measure is worth 10 points, your entire cost category score would be out of 10 points. There are some situations in which you could be eligible for more measures, and you just take the number of measures you're eligible for times 10, and that's your maximum possible cost score. How CMS determines how much it contributes to your final score is they take they multiply that performance rate by 100 and then multiply that by 0.3 and you get your weighted score. Now, cost is scored in real time, unlike most of the other categories. But we don't have access to any of that data until the July or August following the performance year when CMS releases final scores. Because of that, there's not much you can modify during a performance year unless you get feedback from a prior performance year. So take a look at the feedback that you got from 2022 and see if you can apply any changes moving forward. That's going to be really important for those that want to improve their 2024 cost scores. Like I said, it's worth 30% of your MIPS final score. And unlike the other categories, there's no work to report this category. It's done via administrative claims. CMS calculates your score on the back end. Now, here's a quick cross-section of the cost measures. There are, I believe, 23 cost measures in 2024. The ones most relevant to our specialists are seen here on this slide. The two procedural episode-based cost measures are cataract cost and melanoma resection, because those are two procedures. Procedural episode-based cost measures have a 10-episode case minimum, meaning you have to have 10 qualifying procedures. So if you have an exclusion for one patient because they have a complicating condition, for instance, that patient wouldn't count toward that case minimum. If you reach that 10-episode case minimum during the performance year, you will get picked up on the measure. There is also a chronic condition measure that was pretty commonly attributed in 2022. That's the diabetes cost measure. This has a 20-episode case minimum. And then there are two general cost measures. There's the total per capita cost measure, which has been around since the value-based modifier. This measures any provider that provides care to a patient using a primary care E&M code, so basically any office visit. However, specialists like ophthalmologists, dermatologists, plastic surgeons, orthopedic surgeons, etc., are removed from this measure, and they remain removed in 2024. I do want to note that mid-level providers like NPs and PAs are considered primary care providers by CMS's two-digit classification code. So for the time being, and this is something that we're working on, if you group report and you have PAs and NPs billing under your TIN, you could get picked up on the total per capita cost measure. So that's something to keep in mind. And then finally, there's the Medicare spending per beneficiary measure. Outpatient specialties should not see an MSPB score because this is an inpatient measure with a 35-episode case minimum. So next up, there are some exciting changes to costs in 2024. This one actually starts this year in 2023. So starting this year, the diabetes cost measure will have a different attribution than it did in 2022. A lot of groups with specialists that didn't treat diabetes, did not manage diabetes, got picked up on the diabetes cost measure in 2022. This is changing. So anatomy IT policy staff were actually the first to recognize that this could be a problem. We brought it to the attention of specialty societies, the AMA and CMS, and through tireless efforts, CMS has agreed to change the way groups are attributed this measure. So in 2022, at the individual level, in order for an individual clinician to get attributed this measure, they would need to have prescribed 2 or more condition-related medications to 2 or more patients during the current and prior performance year. So condition-related medications include things like insulins, metformins, ACE inhibitors, and ARBs. So unless you're in endocrinology or managing diabetes as a primary care physician or in cardiology, this really isn't something you should get picked up on. However, at the group level, CMS left the attribution without the condition-related medication requirement in 2022. Unfortunately, they weren't able to go back and change scores from 2022, but moving forward, they're applying that medication requirement for attribution at the group level. So at least one of your clinicians under your TIN would have to meet that 2 condition-related medications to 2 or more patients requirement. So this is huge, and it should exempt most specialists that don't manage diabetes from this measure. One other change to the cost category in 2024 is the cost improvement score. CMS finalized the addition of the cost improvement score last year, and it was originally measure specific. So in order to get a cost improvement score, you would have to be scored on the same cost measure for sequential years so that they could measure year-over-year improvement on that measure. That was really difficult to implement. So CMS has changed that, and it is now category specific. So they're going to look at your entire cost category score and see if you have improved from the prior year. And that's the same way they do it for quality. And just like quality, you can get bonus points. For cost, you can get up to 1% of your total cost score added on as points before the weighting of the cost score goes into the final score. So you get up to 1% added to the cost category score, which is pretty great. We're hoping to see a lot of that next year. So that's it for cost. Because this is an overview webinar, I don't have time to go into each individual cost measure, but feel free to reach out to us later if you have questions. But let's move on to the EHR category of MIPS, promoting interoperability. So this is a pretty familiar category. It's been around since the meaningful use days. It's just gone through a lot of name changes. But there was also a pretty big change this year to the category. Instead of a 90 consecutive day reporting minimum, which has been the requirement since MIPS started, starting in 2024, it will be a 180 consecutive day reporting minimum for PI. So that's half the year pretty much. So this is going to be really important if you have EHR updates or you're transitioning EHRs, because it can be really difficult to get information to transfer from one EHR to another for the EHR measure calculations, or it can also be really difficult to start up on a new EHR and make sure that you're doing the measures correctly so that they're getting recorded by your new system. So really be mindful when you're doing EHR updates in the next year. Just like last year, the 2015 Cures Update edition of Certified EHR Technology, or CERT, is required. The category is out of 105 points because there is a 5-point bonus measure, but you can only earn up to 100 points. Unfortunately, there's nothing over 100% for this category. And really unique to this category is that you have to report on every single measure. If you get a 0 on one measure, that gives you a 0 for the entire category. So you have to either check a box for yes if it's an attestation measure, have a numerator of at least 1 if it's a performance rate measure, or claim an exclusion for each measure to avoid getting a 0 for the category. And as I mentioned earlier, it's worth 25% of the MIPS final score. Now, this is really important. Really make sure that you do not report PI more than once. If there are any differences between your PI reports, if you've reported more than once for the performance year, even if one PI performance period starts maybe a day earlier or later, CMS will give you a 0 for the category. So be very careful to only report this category one time. Make sure if you're reporting through a QCDR, make sure your EHR isn't reporting it, so on and so forth. So major changes, I already mentioned, there's a 180 consecutive day performance period now. The SAFER guide, high priority SAFER guide measure, that used to be you can say yes or no and you'll get credit. That attestation is now required to be a yes. And the query of PDMP low volume exclusion has changed. Previously, it was if you prescribed 100 or fewer than 100 permissible prescriptions. Now it will only apply to clinicians and groups who do not e-prescribe any Schedule II opiates or Schedule III or IV drugs. So this is an overview of the measures for 2024 PI. All of these have stayed the same. There have been no changes to measure names or the number of measures. The points remain the same as well. Really, the only big change we're seeing here is that exclusion I just mentioned, and it's highlighted on the right side of your screen. And we're going to be posting the recording of this and sending it out, so don't worry about taking screenshots. So as I mentioned, the query of PDMP measure now has a different exclusion. You can't prescribe any Schedule II opiates or Schedule III or IV drugs. If you were a low volume prescriber this year, but you did prescribe scheduled medications, really pay attention to this because you probably won't qualify for that exclusion in 2024. So one other thing I would like to mention about the measures is the public health and clinical data exchange measures. There's no change to the measures themselves in 2024, but the change last year was pretty big, requiring both electronic case reporting and immunization registries mandated. I want to make sure that I mention that if you have not already reached out to your state, because this varies state by state, to see if you qualify for any case reporting. So if you treat any conditions in some states, it's even if you suspect a condition. So that's considered a reportable disease for that state. So really check with your state. For some states, it's going to be easily available on the website. For some, you may need to reach out via email, but check with your state and make sure that you are doing what you need to for case reporting. Most states have declared readiness for electronic case reporting. So option 3, exclusion 3, isn't really going to be available for most states. We have a new blog that we're putting up shortly after we confirm things with 2 additional states. And it'll tell you which ones are ready. And you can use that blog for the entire year because it does say declared readiness within 6 months prior. So once that blog is out, you'll know if your state has declared readiness or not. And same with immunization registry. If you don't immunize, you're golden. You could just take exclusion 1, but really pay attention to the electronic case reporting measure. Another thing about this is not a change in 2024. This was a change last year, but they made the change last year. They finalized it to begin in 2024. So CMS limits active engagement option 1, which is basically registration and kind of getting ramped up, but not in full data sharing, not in full EHR integration with your electronic case reporting registry or any registry. They're limiting that to 1 year per registry. So if you have already registered for electronic case reporting and you can't get fully into full validated data protection in 2024, that's fine. But starting, if you have reported that you're in option 1 in 2024, that won't be okay for 2025. So the clock starts in 2024. So if you are in option 1 in 2023, you can be in option 1 in 2024. But if you are in option 1 in 2024, you have to move on to option 2 for 2025. Just want to make you all aware that the clock is starting in 2024. Some states take a very long time to onboard. Some EHRs have more difficulty than others, and a lot of states have wait lists. So make sure that this is something that you get on sooner than later. And there's more information, like I mentioned, on our blog. It's anatomyit.com/blog. The web address will be on the last slide as well. So as I mentioned, there's also a change to one of the PI attestation requirements for the SAFER guide. It is now required that you attest yes. Previously, you could attest yes or no, and it was totally fine. Now, there has been a lot of anxiety over the safer guides, but they're really not that difficult. So although it's quite long, the high priority safer guide does walk you through step by step with explanations every single question that it asks. Some of them are multiple choice, some of them are free response, but it is very useful. We highly recommend that you take a look at the safer guide and complete it every year. If you don't complete it, you can't attest to it in PI starting in 2024. But with the extreme increase in cyber attacks against healthcare, we think it's good for your practice, it'll save you money, and it doesn't take that long. Another important thing to mention is the security risk analysis. Now, I have heard from a lot of practices when I first introduced this to them that they didn't know that they should be doing this frequently, even without the MIPS requirement. Under HIPAA, you're supposed to do a security risk analysis anytime there is any substantive change to your practice, like hiring new staff, transitioning to a new office, switching EHRs, et cetera, et cetera. So it's a good practice to get into to do this annually, even if you're not reporting PI. So when you're doing a security risk analysis, you're not just looking at what's in your computer. You're looking at any place where PHI could be. So that's obviously electronic protected health information, obviously your EHR and the computers, but it's also any printed or written material, scheduling, copiers and fax machines keep a log of things that they have copied and faxed. So that's also really important to take a look at. And despite common misconceptions, there are actually 5 security categories: physical, administrative, safeguards, policies, procedures, organizational requirements. Those 4 are in addition to technical safeguards. So make sure that when you do your security risk analysis, you're analyzing all 5 of those categories and not just the technical one. There are a lot of ways to do this. You can use your EHR vendor or IT company. Again, make sure that they're not just looking at the technical safeguards. We offer a service. We'll do everything. We'll lead the assessment and make sure you have peace of mind. Reach out if you're curious, or you can do it on your own. ONC has a free risk assessment tool. Like most government tools, it is a little clunky, but because it's from ONC, you know it's got everything. And that's it for PI. I tried to keep it short, so I hope it was clear. But now we're going to move on to my favorite category, improvement activities. So there have been pretty much no changes to the basics of improvement activities. It's still a 90 consecutive day reporting minimum. The entire category is still out of 40 points. There are still high priority and medium priority measures, medium being worth 10 points, high being worth 20 points, and double that if you're in a small rural or health professional shortage area practice. And it's still worth 15% of the MIPS final score. What has changed is there was a modification to a clinical decision support protocol improvement activity. It's not a very heavily used improvement activity, so it's not really going to impact many practices. There was a removal of 3 improvement activities, none of which really impact our practices, and an addition of 5 new improvement activities, including practice-wide quality improvement in MIPS value pathways. That's high-weighted. In order to use that, you must be reporting under a MIPS value pathway. There are still very limited selection of MIPS value pathways and none that are relevant to dermatology or ophthalmology. There are some ortho ones, however. And a second one that could be used if you're looking for another improvement activity is behavioral or mental health and substance abuse screening and referral for older adults. This is also high-weighted. So that's it for improvement activities. And I am seeing a lot of questions in the chat. We will definitely go over these when we get to the Q&A portion, which will be after quality. So last category, home stretch. Quality, it's a full year reporting period. You can earn up to 60 points within the category. You must submit at least 6 measures, one being an outcome or high priority measure, and it's worth 30% of your MIPS final score. There are bonus points available if you're in a small practice, and that's 15 or fewer eligible clinicians. And for improvement. So your category specific improvement score, you can get up to 6 points. You can report this category through claims if you're in a small practice, through your EHR, through a registry, or through a qualified clinical data registry. So no changes on measure scoring, but I do want to make sure that everybody knows how measures are scored because it changed in recent years. Previously, measures were scored from 3 to 10 points. That's changed. Measures are now being scored from 1 to 10 points. In order to be scored from 1 to 10 points, that measure must have a benchmark. You must report case minimum, which is 20 patients, and you must meet data completeness, which is reporting on at least 75% of the denominator eligible patients for that measure. Denominator eligible patients are patients that are basically eligible to be reported on for that measure. For example, in the diabetes eye exam measure, it's 75% of your patients 18 to, I believe, 65 that have diabetes. For a different measure, obviously, it's a different population because it measures a different population. Now, this is really important to keep in mind because if you don't have any one of those 3 criteria, meeting a benchmark, reporting case minimum, and data completeness, if you're a large practice of 16 or more clinicians, you get 0 points for the measure. Doesn't matter, no points. If you're a small practice that's 15 or fewer clinicians, you get 3. There are special scenarios, however, so if a measure is in its first year in MIPS, it will have a 7-point floor. And if it's in a second year, it will have a 5-point floor. So the measure scoring you see on the left is general, with the special scenario being if it's in its first or second year in the MIPS program. Now, important to note, if a measure undergoes substantive changes and loses its benchmark, it does not restart MIPS as a first or second year. It just does not have a benchmark. And then another important thing to note is data completeness. This wasn't a new policy. This was finalized last year for 2024. It's now 75%, up from 70%. And it's going to be going up to 80% in 2027. So quality measure changes. There are 11 new measures. There are 59 existing measures with substantive changes, and there was a removal of 14 measures. And now I'm going to hand it over to Renee. She's going to go over the top finalized measure changes for ophthalmology and dermatology. And Renee, our Director of Value-Based Care, take it away.
All right. Thank you, Jessica. Hi, everybody. So we're going to start with ophthalmology first. So in ophthalmology, there are several important measure changes. For measure 14, which is age-related macular degeneration. This measure is looking for a dilated macular examination. The dilated macular examination has been removed from MIPS beginning in 2024 because it has been topped out and at an average score of 95 plus or more percent for too long, and CMS believes it no longer addresses an area in which improvement is available. And then for measure 19, diabetic retinopathy, communication with managing physician, CMS finalized a clarification that the dilated macular fundus exam must be both performed and communicated to the doctor managing the patient's diabetes during the performance year. That part is key. So this means that for exams in late December, you want to ensure that prompt communication for a patient is sent, so that way the patient can be favorable for the measure. And then to align with the ECQM version, the MIPS CQM version of measure 117, which is the diabetes eye exam, will allow for AI screening for diabetic retinopathy to satisfy the numerator beginning in 2024. There's also a new medication added to the denominator exclusion list, which is dinezapril memantine for dementia. And then measure 141, POAG reduction of IOP by 15% or documentation of plan of care. It's a very wordy title. It actually has a new title. It is just as long though. It's now primary open angle glaucoma reduction in IOP by 20% or documentation of plan of care. This new title corresponds to a change in the requirement to satisfy the measure. A reduction in IOP of 15% will no longer satisfy the measure. It now requires a reduction of 20%. It also, and then the name title even implies where it says or, so it's a reduction of 20% or still a documentation of plan of care. And then finally, measure 191, cataract surgery 20/40 or better visual acuity within 90 days following cataract surgery. Wish that one had a measure title change. That one has an update to the ECQM. Surgeries performed January 1st through September 30th, and just plug in that this includes those on September 30th, are included in the measure. This was the original intent of the measure, so it's just a minor revision in line with measure intent. All right, next slide. Okay, so I'm so sorry too. I had notes listed with this, and I'm just don't have that. I think I lost the page that was open. So these are 3 new retina measures. So the first one is measure 499. This is appropriate screening and plan of care for elevated IOP following intravitreal or periocular steroid therapy. So this measure is looking for patients without a diagnosis of glaucoma who had an intravitreal or periocular corticosteroid injection, who within 7 weeks following the date of the injection are screened for elevated intraocular pressure, IOP. And then to be favorable, they're looking for either a documented IOP less than or equal to 25 mmHg for the injected eye, or if the IOP was greater than 25 mmHg, and then a plan of care was documented for those patients. So it's somewhat similar to measure 141 with the IOP reduction or a plan of care, obviously different and for a different diagnosis. Measure 500 is acute posterior vitreous detachment, appropriate examination and follow-up. So this is for patients with a diagnosis of acute posterior vitreous detachment or PVD in either eye who had a vitreous exam and peripheral dilated exam with scleral depression that were also reevaluated up to 8 weeks from the initial exam. And then the last measure that's new is measure 501. This is acute posterior vitreous detachment and acute vitreous hemorrhage, appropriate examination and follow-up. These just measures names just keep getting longer and longer. So this is for patients with a diagnosis of acute posterior vitreous detachment or PVD and vitreous hemorrhage in either eye who had a vitreous exam and peripheral dilated exam with a scleral depression that were also reevaluated up to 2 weeks from the initial exam. All right, next slide. Then moving on to dermatology and plastic surgery. So in dermatology and plastic surgery, there are finalized changes to 3 measures. So the first one is measure 138, melanoma coordination of care. This measure has been removed from MIPS beginning in 2024 because it has reached the end of the topped out life cycle. And then this for both of the measure 485 and 486 on the screen, and the patient reported itch severity for both psoriasis and dermatitis, CMS has made 3 important changes. The first one, this measure must now be reported on a broader range of patient ages. Previously, it was reported only on those 18 or older, and beginning in 2024, it must be reported for patients 8 years and older. The second one is the itch severity improvement requirement has also increased from 2 or more to 3 or more. So they're looking for 2 or more in the reduction of the score, 3 or more reduction. And then finally, given the new age range, CMS added a clarification that the VRS tool is only for patients 18 and up. All right, next slide. All right, so these are just some general measure updates. So since we report on some general measures for our specialties, we listed them here. Of note, several of the screening measures have been removed, for example, BMI screening, and indicated by an asterisk on this slide. And it's replaced by a more comprehensive preventative care and wellness measure. So it's not all of them, but several of them have been combined. One measure that I do want to call out that has an asterisk is measure 402, tobacco use and help with quitting among adolescents. This measure has now been merged with measure 226, the adult tobacco use and screening. So instead of patients 18 and up for the measure 226, it's now patients age 12 and up. If you report on some of these measures, check out our guide that we posted on our website in our 2024 MIPS final rule blog. And we'll also, if it hasn't been added, we'll add that to the chat as well. And that wraps up our discussion of the 2024 MIPS final changes. And we now want to go ahead and open the floor to Q&A.
All right. Great job, Renee. Thank you. So I'm going to take a look at some of the questions we've got in the chat first. So Melissa, you asked a question about data completeness for physicians that are practicing, that see patients in nursing homes, SNFs, hospitals. How do you report on those patients? So that really depends. It depends on how you bill for those patients. Are you billing for those patients under the same tax ID number? If so, those patients would need to be captured. If you're billing them under a different tax ID number, then they would not need to be captured for data completeness, because CMS considers CMS requests reports at either the TIN level or the TIN MPI level. So for instance, if I were practicing under two different TINs, two different tax ID numbers, for the purposes of MIPS, I would be considered two different clinicians. And feel free to raise your hand also if you'd like to ask a question out loud. Jennifer, if you wouldn't mind calling on people so that I can keep an eye on the chat. So there was another question about whether or not the quality measure changes we discussed meant that measures wouldn't have benchmarks anymore. I just want to make sure I say this out loud for those not following the chat. It's possible that measure 141 may lose its benchmark, and the itch severity measures, they don't currently have benchmarks because they're in their second year of MIPS anyway. So they wouldn't be losing their benchmark. But 141 had a pretty substantive change. So that one may lose its benchmark. We won't know for sure until CMS releases the 2024 benchmarks file. That won't happen until probably late January at the earliest. Okay, there's another question in the chat. It's asking, can we touch on when to report as a group versus individual and what the pros and cons are of both? Renee, would you mind taking this one since you do more boots on the ground?
I'm sorry, you said, is it the last one? Can you touch on when to report as a group?
Yes.
And pros and cons of both? Okay. So for group reporting, I'll just give an example from an ophthalmology practice. So say you have cataract surgeons and retina specialists as well. And by doing group reporting, let's say even more dramatically, it's mostly cataract surgeons, glaucoma, and maybe one retina surgeon. So by doing group reporting, the practice is able to benefit from all of the retina measures and report on it at the group level, even though only one clinician contributes to that score. So that's where a huge benefit can come from. Another benefit, again, just staying with ophthalmology as an example, for cataract surgery, if say another clinician within your practice may see patients, or you have some co-management where they may send the patient over to the optometrist for any post-op visits, because that measure is, if you do individual reporting, then they're only looking for data under that particular clinician. So if another clinician sees the patient post-operatively, then the patient would be unfavorable because it wasn't captured under the clinician's name. If you're doing group reporting, they're looking to see if the patient was seen at any point during the post-op period within that entire group or tax ID. There's multiple other examples. As far as a con goes, I mean, so I listed several pros. As far as a con goes, let's say, for example, there's several clinicians within a group that are not individually required to report, but they're maybe half and half. If the quality score or the PI score, one of the category scores, you don't expect it to be an excellent score. Well, if the clinicians are only group eligible and say you get a minor negative payment adjustment, you could have avoided those group eligible only clinicians getting a negative payment adjustment by switching the practice to report individually and only report on the clinicians that are required to report. But on the flip side, take that same scenario. If there is likely to be a modest or a higher positive payment adjustment, then it's in the best interest, because then those group eligible clinicians can have that positive payment adjustment applied to their Medicare Part B claims. I hope that was clear. I know I said a lot there.
Yeah, that was great. Yep, that you even got feedback on the chat in that. So now we have another question. It says, we're struggling with measures as a dermatology practice, especially with 138 being removed. Renee, I think this is another question for you. Is our only choice to use a measure that is irrelevant to our care? Seems like that defeats the purpose of trying to control cost and quality of care.
So completely understand why you're asking that. I smiled when I read the last sentence, just that we agree with you as well. So technically, yes, you can report on a measure that is irrelevant to your care. Thinking about how much of a impact does it have? Is it a in-person impact, or can it be done administratively? So when I say administratively, I'm thinking about maybe measure 374, closing the referral loop. That's something that can be managed during downtime and doesn't have to be done right while the patient is there. But yes, you're not the only practice and even specialty that struggles with some measures getting removed and not ultimately replaced. One thing that I do want to plug are QCDR measures that are available through DataDerm, which is the American Academy of Dermatology's approved MIPS registry. So DataDerm has QCDR measures that are only available through their registry. Typically, the vast majority of those measures are based on clinical findings that don't require, clicking a lot of buttons or adding anything extra. It's maybe there's a surgery and they're looking to see if there was an opioid prescribed. So it's just simply based on clinical findings. So those are some great ways to boost your score if you're able to report. There is an added charge to use DataDerm. When we work with our practices, we like to talk about the options, possibly do a combination, try to use DataDerm, but then if we don't need it, so if we're doing kind of an EHR DataDerm combo, those are things that we definitely talk through and strategize with the practices we work with.
Okay, so I see another question here that's asking who suggests MIPS quality measures. Again, it's about struggling with getting enough quality measures that are germane. CMS does suggest some of the MIPS quality measures. Currently, every year in December, CMS, through a contractor, releases what's called the MUC list. It stands for Measures Under Consideration. And that's kind of a preview of changes that CMS is trying to make. CMS isn't the only one that puts forward measures, but these measures must be tested and considered valid. So there is quite a high bar for any MIPS measures. So that's measures that don't have a QCDR name right before them. Alternatively, you can also report QCDR measures like IRIS or DataDerm measures. And those are measures developed by the QCDR and only reportable via a QCDR that is licensed to report the measure. Those measures are a little more nimble because they are finalized through what's called the self-nomination process. It happens outside of rulemaking. But yeah, it's a really long road to get new quality measures through the traditional rulemaking process. If you're struggling with that, I encourage you to reach out to your specialty society and let them know if you're interested in helping them develop measures, see how you can get more involved. That's always a great way to make sure that your clinical practice is being reflected in the measures. Let's see. Scrolling through the questions.
So Jessica, there's one, is there an updated MIPS estimator tool that we used to use for both 2024 and 2023?
I'll let Randy take this question.
Yeah, so if you've used our ValueView tool in the past, we have not have that updated for this current year, but we are making changes and plans for how to address that in the future. What I would recommend is if you are using a registry or your EHR, it may have built-in estimation capabilities to give you your score throughout the year. It's something we think is very important. That way you're only working on what you actually need to do and not just trying to do everything and see how you fare at the end of the year. And if you do need help with calculating your score and figure out how you perform, that is something that we offer as part of our MIPS success plan.
All right, great. I'm seeing a couple questions on if you're reporting as a group, who do you have to report for? So one scenario states that they have 5 dermatologists and 2 independent contractor Mohs surgeons. They want to know if they can report as a group and not include the Mohs surgeons in the mix. Very helpfully, you included the detail that the Mohs surgeons do submit under their practice TIN. So if they are submitting under your TIN, you have to include their data. So if they have basically reassigned their billing rights, especially if they're under a PAYCOS, to bill under your TIN, they are included in your practice. And by regulation, any quality data that is generated by your practice has to be reported if you're reporting at the group level. Even if, let's say, you hire someone at the beginning of the year and they only last for a month before, say, they have to move, that person was still part of your practice for the year, so you would have to report on the data that they generated as well. There was also a question asking if it's somebody's first year with the company, would you have to submit data for them? The answer is yes, you have to submit data for all eligible clinicians that are in your practice. So unless they registered for and became a registered Medicare provider during the performance year, so after January 1st, the timing of their practicing does not matter. So if they just joined your practice, but they've been providing Medicare care before they joined your practice, yes, you absolutely need to report on their data.
Just to jump over to the Q&A side, I have questions from Teresa around the electronic case reporting. Do we need to apply for an exclusion for the entire PI category if we can't do electronic case reporting? We're unable to do that at this time, waiting on Next Tech to complete that, and we don't do immunizations. I was under the impression that even if the state was ready, the EMR has to be as well.
Right. So for the first year that ECR was in place, that was the case. There was a 4th exclusion that said basically you couldn't implement it. That went away. That's no longer available. So now if you're having a problem with your EHR not being able to do it, if you can't even register with the state, then yes, unfortunately, the only route available is for you to submit a PI reweighting hardship application stating vendor issues.
Thanks, Jessica. There's also one more unrelated, but we use DataDerm, and the problem is some of the measures are very little point value. I can speak to that. So what you may be referring to is there's measures, especially the newer developed ones, that don't have a benchmark. So the highest score may be 3 or 5 or 7 points, depending on when that measure came out. However, if enough practices report on those measures that don't have benchmarks within the year, if there are enough submissions that are meeting the data completeness case minimum requirements, they will do what's called a live benchmark, meaning they will look at everybody's score and give everybody a score possibly up to 10 points. So I encourage you, I wouldn't stop submitting those, I would keep submitting them. We try to do that as well. There's been a lot of measures that have received benchmarks in recent years due to practices submitting the ones that aren't benchmarked yet. And then once they are reliably submitted for 2 years, then they get historical benchmarks, which are the ones that we see at the beginning of the year that we can use to track performance throughout the year.
Great.
There's also a question, do do the diabetic medications include intravitreal injections used to treat DME and diabetic retinopathy? I assume that's for the diabetes cost measure, and if so, the answer is
for
no.
attribution purposes, they do not. If you're already attributed that measure, that would count toward your cost, but they know that does not count for the attribution medications. They're not considered condition related. So we're really looking at insulins, metformins, ACE inhibitors, ARBs. There may have been a diuretic on there. It's mostly cardio and endocrine.
Yeah, thanks for that clarification. And as you can see, it's a very nuanced, a lot of these cost measures, and they can be pretty complex. So luckily our team is on top of it and analyzing these and getting feedback to our clients. One more thing on the costs from Ashley. Could you please address the cost category for 2022 for ophthalmology? Is there anything we can do now? And what can we do for next year to avoid a penalty in the cost category?
So that's a great question. There's, 2022, that ship has sailed. Unfortunately, the targeted review period is over, and the period on which they were collecting data for 2022 is over. So nothing you can do for 2022, unfortunately. And 2023, that ship is almost sailed as well. What I really encourage you to do is take a look at your score reports and what was contributing to your scores in those Excel files. Take a look at those, what you got for 2022, and really, do an examination. Are there unnecessary tests and procedures that you're doing? Have you not been documenting on a claim prior to the trigger a code that would have excluded a patient? For instance, for like the cataract measure, did they have wet AMD or diabetic retinopathy? And you just didn't include that ICD-10 on a code before the trigger date. These are things to really think about and to evaluate. And when you do that, you can figure out how to optimize the scores for the quality measures. For the cost measures that you've been scored on. Another question I'm seeing in the chat is for quality measures. It's asking about case minimum. If you don't have case minimum, what happens with those measures? So for scoring purposes, you need case minimum to be scored based on how you perform, so your performance rate. So in order to get 1 to 10 points, you do have to meet case minimum. You also have to meet case minimum for measures that are new to MIPS to get above the floor. You don't need to meet case minimum to get the floor, but you do need to meet data completeness. So for small practices, if you don't meet case minimum on a measure that is not new to MIPS, so just a regular measure, not in its first or second year in MIPS, if you don't meet case minimum, you get 3 points on the measure. For a large practice, so that's 16 or more clinicians, you get 0 points. So there was another question, when will CMS release measure specifications? They're supposed to do that by the end of December. Let's see, what else do we have? So
Jessica,
yes,
you might catch it. So let me know if you answered this one, but I don't think so. Would I be able to close sending CCDA from September? I'm assuming this person is referring to like a denominator eligible patient that was added to the measure in September.
Right. So
going with that
what
assumption, if you want to answer.
To ask about.
You
are you
that?
talking?
Oh, okay.
Are you talking, Josephine? Are you? You can unmute yourself, or you can do this in the chat. Are you talking about the PI measure or the quality measure? And are you talking about a patient visit that was in September and you want to send a CCDA out for PI, or what specifically are you wondering there? And while we wait for Josephine, we have some more questions that have come up. So
one really quick is to find out when the presentation and recordings of the webinar will be available. So we answered in chat, but just to verbally say, we're going to send out the recording and post it in our blog as well.
Yes, we will. So let's see.
Josephine
Another
answered
question.
you.
Okay, a CCDA was sent but not recorded to close sending for. Okay, so your EHR, it sounds like, Josephine, how about you email us? Because I have a feeling this is going to be a bit of a discussion, a little bit of back and forth, and I want to make sure I give you the correct answer. If Jennifer, if you wouldn't mind putting the MIPS email in chat. So another question that we've received is similar. It's what to do if you haven't received a summary of care CCDA document from your referring providers. This is for the receive and reconcile measure for promoting interoperability. So what we recommend is that you reach out to providers that use your same EHR. If you know which EHR they're on, that way you can walk them through how to send you a summary of care so you can reconcile it by the end of your PI performance period. Or you could try reaching out to a large primary care practice that sends you a referral, or a hospital. They often know how to do this and have that functionality enabled. So those are our recommendations for that measure. As long as you receive and reconcile at least one measure, one summary of care CCDA for a referral that you've received, you're okay. So as long as that's done during the 90+ consecutive day performance period that you choose, you're golden for that measure. So another question that I'm seeing here is that someone that asks that they receive a lot of referrals, but none of them electronically. They have a direct mail address and have shared it with the referring practices, but they're all mostly small optometrists and don't have direct messaging, and in some cases, no EHR. What exclusion can I use? So that is a great question. There isn't a good exclusion for this. What I would recommend is that for the practices that do have an EHR, again, reaching out for a specific patient during the performance period and requesting it, or a practice that's on the same EHR and hospital, kind of like I mentioned earlier. There isn't a specific exclusion for practices that refer to me don't have an EHR, unfortunately. Randy, I saw you unmute for a moment. Do you have something to add?
Yeah, so there's some additional strategies to keep in mind. So if you do have that direct address, make sure you have that registered in your provider's profiles on the NPI registry site. Also, you can look up other doctors that have also put their information in there as well. I've also found sending out like a campaign to your top referring providers, letting them know about this. Also, keep in mind, direct mail is usually what your EHR is going to have built in by default that they were required to have set up. But, and correct me if I'm wrong, Jessica, but it doesn't have to be direct mail as long as it's a secure transport method. That can be, the CCDA can be sent during another way. So while we know a lot of practices don't have, a lot of smaller practices may not have an EHR, having encrypted email, they should definitely have. Or if you have encrypted email and you're sending it to them via your encrypted email, that would suffice as well.
For
so
the
if you can send them an email, then they can respond back into that secure email with the file, then that would suffice as well.
Yeah, that works for the sending measure. So one of the details of the HIE measures, health information exchange measures, is that the summary of care document must be generated using certified EHR technology. So if you're generating that document and sending it electronically, even if it's through a secure email, as long as it's in a format that, were they to have an EHR, they could reconcile with their EHR, which it would be, that would count. But for the receiving measure, because it has to be generated by a certified EHR, the CCDA, the referring provider has to have a certified EHR in order for that to work. They can't just email. All right, so next one. So another question that we've been getting is, we were approved for an EUC, an extreme and uncontrollable circumstances hardship for 2023 because of COVID. Can we do that again for 2024? The answer is yes, you can. One thing that I caution is CMS is required by law to do random data validity audits. So you might have seen these data validity audit emails or announcements for MIPS. If you don't actually have a hardship that is related to COVID, getting that hardship could be really tricky to justify if you get audited. So I really recommend that you be very careful about anything that you submit. And I caution everybody on this call that lying on a federal form is a federal offense, and that submitting incorrect data to CMS on MIPS is actually a criminal offense. So make sure that you're being truthful. CMS has been very adamant about that. They've had some pretty stern language in some of their MIPS regulations. So we just want to make sure that that disclaimer is out there. So I'm seeing another question. Why did PI switch to 180 days? So the PI switch to 180 days is the rationale behind that is multifactorial. So one factor is that is what it is for hospitals. CMS has been trying to align the programs so that the requirements for hospitals and physicians are more and more similar. They think that this will reduce administrative burden for hospitals that have to report multiple programs. Another reason is that CMS is concerned that 90 days of doing what they're saying are these really important measures that can actually impact patient safety because of access to information for referring providers receiving referrals, even for patients to access their own accurate information. Like, that's really important for patient safety. So they stated because that's important for patient safety, we're concerned that doing this for only 90 days, it does a disservice to the Medicare population. So they increased it to 180 days. We did let them know that we were concerned about the impact of switching EHRs because we've seen a lot of issues with having to change the planned performance period for PI because of an EHR transition or a decertification. But CMS really feels strongly that 180 days should provide sufficient flexibility. So there's another question in the chat. Can you elaborate on how switching?
Sorry, Jessica, I don't mean to interrupt, but we are now almost 10 minutes over our time. Also, actually, with the chat message. So, Janetta, I know you and I work together. So if you'd like, just since we are 10 minutes over our time, if you want to send that email to me, and I'll be able to help explain it. I know you also have a lot of complexity with multiple acquisitions within your group.
All right, great. This has been wonderful. Thank you all for attending. If you want to set up a consultation, the email is on the screen. Please, whether you work with us or not, please do visit the Anatomy IT blog because that's where you're going to see a lot of this information, a lot of MIPS updates and news. And I hope you guys have a great day and a great holiday season and a great MIPS reporting season.
Thank you, Jessica.
Thank you all. We'll send the webinar out later today.